Hi, everybody. Thank you very much for joining for your lunch. Sophie's team is very pleased to have the chance to entertain you for this lunch, thanks to three great speakers about hydrodynamics and shunting and the management of the complication of shunting. So I will give the floor to Alexandra Vallée, coming from Norway, and she will introduce you some very interesting thoughts about hydrodynamics of CSF and of shunting.
Thank you. Good afternoon, everyone. So I would like to thank you to give me the opportunity to talk to you today about the perspective of combining two views, one which is physics and the dynamics of fluid, and the view of CSF physiology and clinics. So I'm from a physical background. And so I was working in Norway at the University of Oslo, and now I just have an associate professor position in France, in Saint-Étienne. And so I come from the world of physics, so I tend to see the world through the lens of forces, energy, and motion. And so today what I would like to share with you is to make like a recap about the basics of fluid dynamics and how we can apply it to CSF physiology and to understand the CSF system. So I will start with the basics from fluid dynamics and what is pressure. So fluid particles are in constant motion. That's what we call buoyancy. And these motions create collisions in between the particles. And each collision creates tiny forces, and they're really tiny. But when you have billions of those tiny collisions, then you have a significant effect. And each of those forces, if you apply it on a plane, on an area, that's what we call pressure. Pressure is the sum of all those collisions. And now, if you have what we call a gradient of pressure, it's when you will have more of pressure on one side of the plane compared to the other side. And because of this disbalance of forces, you will have a movement. So this is one of the main driving forces for fluid, is the gradient of pressure. Now, what we see is that with the particle interacting in between each other and with the wall, we have what we call friction. And this friction will act as a resistance to the flow. And when you have friction, you will have to impose a higher gradient of pressure to impose the fluid motion. And this friction depends mainly on the geometry of the system. It depends as well on the viscosity, and the more the fluid is viscous, the more you will have those interactions between the particle and the walls, and more friction you will have. So it will be more hard to push the fluid through the system. One last important thing that drives fluid dynamics is gravity. So each particle of fluid is subjected to the gravity force, and it will weigh upon the particle below it. So each particle is dragged toward down, and then you will have an increase of pressure as you go deeper through the column of liquid. Usually, we write the change of pressure due to gravity as rho gh, where rho is the density, g is the acceleration due to gravity, and h is the height of the column of liquid. And what is important to see in this formula here is that it doesn't depend on the geometry of the column of liquid. It doesn't depend on the shape or the area. It just depends on the height of it. And if we take a typical 55 centimeters, we arrive with a 40 millimeter of mercury change of pressure due to gravity. So now that we made a recap about the main driving force in fluid dynamics, I will introduce important concepts that are used to describe CSF physiology. I'm sure you are you all know about it. So compliance. To describe compliance, you can imagine like a balloon which is filled with fluid, and as you increase the pressure of the fluid, the balloon will deform. And this deformation will depend on the mechanical property of the wall of the balloon, but it will depend as well on the pressure which is outside the balloon. And it's the same with CSF system. When you change the pressure inside the CSF, the system will be able to deform, and then you will have a change of the volume. And to describe this behavior, we use here the compliance, which can describe the change of volume in relation to the change of pressure. And this compliance is nonlinear. What we see is that for small CSF pressure, we will have high compliance. Typically, it's 0.5 milliliter per millimeter of mercury. But when you increase the CSF pressure, the compliance increases. And decreases. So we have a more stiff system, and the same change of volume will lead to a larger change of pressure. So usually we can explain this in biological system because of the mechanical properties of the wall. As you stretch the balloon, you can see in biological systems that there are fibers, and the fibers are stretched as well. And when the fibers get straight and really stretched, it's not possible to stretch them more, and then the system becomes more stiff. So usually that's how we explain the nonlinearity of elastic properties in a biological system. Another way to explain this behavior can be done by thinking that the compliance is due to the collapse of the vein. And then when you increase the pressure of CSF around the vein starts to collapse. And at some point, the vein can't collapse more, and then we get a more stiff system. So by looking at the collapse of the vein, we can as well explain this behavior. Another fundamental concept that we use to describe CSF physiology is the hydraulic resistance. When you have those friction force that I told you about before, in fact, you lose energy. So the fluid which is going through the system is losing energy because of friction, and this energy must be taken somewhere, and it's taken from the pressure energy. So when the fluid goes through the system, due to friction force, the pressure decreases. So we can see it here. I show some example in simple geometries. We have a pressure drop due to frictions, and usually for a tube we can write it this way, where the drop of pressure will depend on the flow, and it will depend here mainly on the geometry of the pipe and on the viscosity. And here what is in green is what we call the hydraulic resistance, which will describe the relationship between drop of pressure and flow. So to give just some order of magnitude, if we take this length for the Sylvius aqueduct, and we can take two possible radius, here are the resistance that we found out. So it's 10 to the minus 3 in the case of 0.1 centimeter of radius, and you can see that if you divide the radius by 2, you will increase the resistance by 10. So the geometry will have a huge impact here. And now, if we want to have order of magnitude of the pressure drop due to this resistance, let's take the typical production of CSF. You can see that we find really low pressure drop because the Sylvius aqueduct is small. But now, if we take the typical flow due to pulsation, and we will see that later, we have a little bit higher drop of pressure in the Sylvius aqueduct. But now, what we're interested in is the CSF outflow resistance. So this is the resistance for the CSF to exit the system, and typical value in healthy elderly patients are around 8 millimeter of mercury. So if you compare with the value I gave before, it shows you how difficult it is for the CSF to exit the system. So usually, for a long time, we were talking mainly about exit through the arachnoid villi, but now recent papers talk about more exit routes, and mainly through the lymphatic and along the nerves in the spinal cord. So there are many reabsorption routes, and it still needs to be, it's still debated, and it still needs to be studied to understand how this behave. But mainly, we can have a really simple model of the system, a simple computer model, and we can describe the reabsorption as the difference of the pressure inside the system and the pressure outside, where it's reabsorbed. So, for example, the Venus system. And then this will depend, as I show, on the flow and the resistance. So typically, the resistance is 8 millimeter mercury per milliliter per minute, and the flow is around 0.5 milliliter per minute. So you can compare to the total CSF volume, and you can see that we have several times a full change of CSF per day. And then this leads to a typical difference pressure of 5 millimeter of mercury. So if you have a pressure in the vein that is 5 milliliter of mercury, we arrive at 10 milliliter of mercury for pressure. But now, if we increase this resistance without changing the production, what happens is that we have a huge increase of the pressure. And because you have increase of the pressure, the compliance change, and then you will have a change of the pulsation, because the change of volume of the vascular system will lead to more change of pressure. And then if you reduce again the resistance, then you reduce the pressure. But because we have several routes of exit, let's talk about how we can combine resistance and what happens when you have several resistance in the system. So if you put the resistance in series, like let's say we have one resistance and then a smaller conduit with a higher resistance and then a third resistance, you can express the total resistance as the sum of the resistance. And then what is the most important is the resistance which is the larger, and it will govern the system. So typically in the valve, you will have the catheter, the valve and the catheter. This will be the main resistance here. So we can write the resistance is around R max, and we can still write the behavior of the system this way. But now, if you have several parallel routes, what we write is that the equivalent resistance is the inverse of the equivalent resistance, is the sum of the inverse of the resistance. So here, what will govern the system is the route with the lowest resistance. In fact, the flow will take the path where it's the most easy to go, so the lowest resistance. So we can still have an equivalent resistance and write the behavior of the pressure inside the system in this way. But now, what if for each route we have a different outflow pressure outside the system? How can you describe the system? Can we still describe the system this way? I guess it's possible if all this pressure are really small and we say it's zero, but if it's not the case, how do we do? So this is to show that it's a bit more complex, and this needs still to do more research to understand the system in different physiological conditions. Now let's talk about the coupling with the vascular system, because CSF system is strongly coupled with the vascular system. At each cardiac pulsation, you have a change of pressure in the vascular system, which leads to a change of volume on the vascular system. We can estimate it by saying that the blood volume in the tissue is around 7%, that we have around 30% of arteries, arterioles, and that at each cardiac pulsation it will deform by 2%. And then we end up with a 0.6 milliliter change at each cardiac pulsation. So this is coherent with what we can measure with the phase contrast imaging. When you look at arterial flow and venous flow, we typically find this order of magnitude for change of volume of the intracranial blood system. And now, by using the basic laws that I showed you before, we can do computer modeling and see how it affects the CSF dynamics. So I took typical value for the CSF system with a resistance to outflow, a production of CSF, a typical compliance, a repartition of the compliance in between the cranial and the spinal compartment, and then I run the simulation. And what you can see is that you have a flow of CSF going up and down in the system, and here I show the flow in the cervical part, and it oscillates with a typical max value of 2 milliliter per second. And you can see that the typical change of pressure induced by vascular component is around 2 milliliter of mercury. But this is still debated. It depends on the publication you are looking at. And what happens now if you change the repartition of compliance? So if you change that, you will see that it will affect how the fluid is going up and down in the system. Because if a compliance is more in the cranial space and not in the spinal, the fluid doesn't need to exit the cranial system and go to the spinal. And then you can see that the flow is reduced here in the cervical, and the volume that go up and down is not the total volume of the vascular change of volume. But there is not only cardiac pulsation in the system, there are as well slow vasomotion, active vasomotion. We can see it in the spectrum, in our encephalography or ICP signal. We can see that we have here really low frequency oscillations. And those active vasomotion, we can as well see directly with two-photon imaging in mice. And in a recent study we've done in Oslo with my biologist colleagues and mathematician colleagues, is that we measured what is vasomotion in mice during sleep. And what we find out is that for arterial, we have huge dilation of the arterial during REM sleep. And during non-REM sleep, we have oscillation, huge oscillation. And those vasomotion can reach up to 20% of the area of the arterial. So this will have a huge effect on the CSF dynamics. So I take again a modeling system, and let's impose a dilation of 20% of the arterioles during 10 minutes. When this happens, it will increase strongly the pressure. And because you increase the pressure, we can estimate that with the law we saw before, it will depend on the compliance. When you increase the pressure, you will increase the outflow, because the outflow depends on the pressure inside the system. So then you exit more CSF. And because you exit more CSF, the pressure will reduce. But then when you go back, and when your vessel contracts again, what happens? Then the pressure will drop, and it will drop below what the level was before. And we won't have, because it's like a valve, we won't have an inflow from the venous system to the CSF. So here we have no flow. And then slowly but surely the pressure increases again to have an equilibrium with the production. So this is what we would predict for long vasomotion. And all this zone here, where we increase the pressure, would lead to what we could call over-drainage. And here it's a reduced pressure when the vessels come back to the normal size. I wanted as well to describe transport, because I think we don't always think about that, but CSF is the main driver for transport in the CSF system. And CSF dynamics and the oscillation of the flow will affect transport. Here I show an example where you put a drop of tracer and you let it diffuse with time. What you see is just diffusion, and your tracer just spread. But now I will impose an oscillation of the fluid. It goes back and forth. There is no net flow, it's just oscillations. What happened is that your drop is spreading as well, but at the end, it has spread much more. So just the fact that you have a dynamic system and oscillation of CSF, you will have apparent more diffusion, and the transport is enhanced. So transport in the brain of metabolics, of nutrients, of metabolic waste depends on CSF dynamics. And this could have an impact in several neurodegenerative diseases, not only normal pressure hydrocephalus, but as well as in Alzheimer's, because we can describe the propagation of neurotoxic proteins using, we need diffusion to describe it. So if CSF dynamics affect apparent diffusion, it will have an effect on propagation of neurotoxic proteins. And this could as well explain experiments that are performed with for example, per Christian Eider, where we look at the evolution of gadobustrol during night, and we see that in sleep-deprived people or not, the transport is not the same. So this might be explained by the dynamics of CSF, which is not the same. So sometimes CSF dynamics is perturbed, and then it needs to have a chance. So here we have a derivation that is imposed. And it has three components: two catheter and the valve. And the valve has several properties that you can choose. And so these are typical values for the resistance we can choose and the opening and closing pressure. The resistance is nonlinear, and for small flows, the resistance is really nonlinear, but for larger flow, we'll have a constant resistance. So if the shunt is the path of lower resistance, then it will be the main resistance in the system. And then you just add up because it's in series, the catheter resistance and the valve resistance. This you can choose. So if we have typical value for the resistance here, and typical production of CSF, we find the same drop of pressure I showed before. And if you have physiological change of about 10 millimeters of mercury, we have this change of outflow. But now, if you change the position, then there will be a lot of things going on. You will have a sudden effect when you change, where the pressure, intracranial pressure will drop because you change the position, and this has been reported in several publications. So this, we would think that it might reduce the outflow. And you will have as well, because of the hydrostatic pressure I showed you before, you will have more and more pressure in the system. So here you will have deformation, and because the spine deform, it will suck the CSF, and CSF will go from the cranial to the spine. So we can estimate it with the formula I showed you before, and an overestimate will be that we have 6 millimeters of fluid that goes in the spine. A better estimate is given in this publication. So we see that a lot of things are going on, but we might have as well vasodilation because the brain needs to keep the flow of blood in the brain. So we might have regulation system going on, and then, as I showed, it will lead to an increase of the intracranial pressure and then maybe a higher outflow. So it's really hard to know what will happen with change of physiological conditions this way. And if now we add the fact that in reality the system is much more complex and that we have all those sites of absorption and maybe all the pressure outside is not the same, and we change with change of posture and change of physiology and regulation, then you can see that it's quite complex, and I think there is still a lot of research to be done to understand the system. So here are my take-home message, that CSF dynamics is governed by a complex interplay in between forces of pressure, gravity, friction, kinetic energy as well. The CSF dynamics depends on multiple parameters: the geometry, the viscosity of the fluid, the resistance, the compliance, elastic properties of all the tissue involved here. And when you implant a shunt, if you have several effects, not only affecting the mean pressure, it will as well affect the compliance, the oscillation of pressure, and it will affect transport in the brain. So the response of the system in time and in various physiological conditions is quite complex, and we still need a lot of research to understand this. Thank you for your attention.
Hello, I'm Guillaume Cole. I'm one of the Clermont-Ferrand hospitality neurosurgeon, and I will discuss today one of the most important topic in the field of normal pressure hydrocephalus treatment, the complication linked to the use of the SOFI valve. So I'm starting with some historical reminders, especially the links between SOFISA and the neurosurgery department of Clermont-Ferrand. The story began in the 1917 at the former neurological hospital of Fontmaur. The neurosurgery department was led by Pierre Jany. This man had made of the intracranial pressure study his main topic. It was assisted by Jean Chazal, who was my mentor. He was retired of neurosurgery 6 years ago. It's supposed to be younger in the 1917s than it appears in the photo, but it did not share with me a picture of this time. So I let you imagine him with long hair, shirt with flower and epistyle. So the two men encountered Bernard Marion, who was a fluid mechanic engineer. This man had a member of his family who was suffering from hydrocephalus. And the main problem dealing with CSF treatment at this time were subdural hematomas and overdrainage. So the three men discussed the idea of an ideal device which could be transcutaneously adapted. So they imagine a device that could be that could be adapted with a transcutaneous dispositif. So the dream became truth in 1985 with the design of the Sofisa valve, which could be setted with a magnetic system. So we will examine the Sofisa series in Clermont-Ferrand. All the patients we studied had the first implantation of Sofisa double pin system between 2000 and 2013. They all received the first surgery in Clermont-Ferrand, and we have studied all the revision for each patient. 697 patients underwent an implantation of double pin Sofisa valve. 98 children, 599 adults. 294 patients were suffering from normal pressure hydrocephalus. 286 underwent a ventriculoperitoneal shunt and 8 an atrioventricular shunt. If we regard the age pyramid, gender ratio was predominantly male. Age at surgery was 70 years old. The shunt complication, if we look at the probability of shunt dysfunction using a double pin Sofisa devices, it's higher during the first years, with a rate estimated at 16% using a Kaplan-Meier estimator. If we regard the shunt failure type, and especially the mechanical complication, they are represented by disconnection and disconnection plus migration in 7.5%, which represent more than 40% of all the complication. And if we regard only the complication due to the Ball-Lincoln mechanism of the Sofie valve, we could see a very low rate with 1.4 over drainage and 0.3% of obstruction of the device. We could not compare ventriculoperitoneal shunt and ventriculoarterial shunt due to the very low number of patients who received natural system in our institution. If we look the delay in function of the type of shunt failure in normal pressure hydrocephalus patient, we can see that disconnection could occur over a very, very long time period, up to 14 years. So I will finish this presentation with 3 key points. The first one is very low complication rates due to the balloon cone mechanism with the SOFI valve. So this device, it's a very, very valuable tool to treat NPH patients. Please follow your patient because disconnection can occur during very, very long time, and do not primary implant supine devices system to treat normal pressure hydrocephalus due to the high risk of disconnection of these devices. Thank you.
Thank you, Guillaume. We thought that it was interesting to compare this series with another one, the one of the Hydrocephalus Center in Beaujon. First of all, I would like to highlight the difference between our series. I think they are not directly comparable because we don't have the same way of treating things. Guillaume is coming from Clermont-Ferrand here. I'm working in Paris. In Paris, we have 9 neurosurgical departments. My department is this one, Beaujon, Northwest, and our focus is on hydrocephalus and INPH. And there is only one department dealing with pediatric neurosurgery, Necker. So in Beaujon, we don't treat pediatric patients, but we treat transitional patients once they grow up and they need care for secondary NPH or childhood onset NPH. The Hydrocephalus Center mainly runs since the middle of 2015. That's the picture of our hospital. There are a few clues about our team. We are focused on normal pressure hydrocephalus. We have set homogeneous protocols for diagnosis, treatment, and follow-up of patients. Our specificity is that we always use lumbar infusion test to assess a normal pressure hydrocephalus and decide to go for shunting. On the surgical point of view, we mainly perform ventriculoatrial shunting under local anesthesia. This is our first-line treatment, and mainly in outpatient clinic. And we systematically use neuronavigation since surgery to ensure that the catheter are in the correct position with only one pass. And we don't think that the most important thing is the tip of the catheter, but that the 2 last centimeters are freely within the ventricle and away from the choroid plexuses. I want to focus again on the programmable valve strategy. You know that the literature is quite scarce about that. We don't even know if it's important to have a programmable valve with no clear differences between fixed valve pressure and programmable valve. Every paper always ends with the idea that it might avoid some surgeries if you can change the setting of the valve. It remains to be evidenced. But anyway, we use that kind of shunts. We always implant the valve in high pressure because of the VA shunting. It is more efficient than VP shunting. And if you use the same valve settings, you get more subdural effusion than in VP shunts. So always in higher pressure and then decreasing progressively each month. And the criterion to choose whether we are going to decrease the pressure or not are based on clinical imaging features and in evaluating the risk. This is the valve we use with, with 5 different settings from 200 millimeter of water to 13. Clinical improvement is measured with the use of the European INPH scale. We don't use the neuropsychological domain because the rate is not in line with the French tests. But balance and walking is very easy to use, reproducible. 100 is a normal value for elderly people. And if you have an increase in 5 in this scale, you can talk about improvement of your patient. We also take into account the subjective improvement, the one we cannot measure, but that the patient or the relatives tell us. This is a very important part of the choice of changing the setting of the valve or not. And we have to compare that, the result we have achieved, to the aim we set before surgery, what we think was achievable in those patients. Second important feature is the imaging. Of course, as you all know, in INPH, the change in ventricular size is not that evident, so this is not the basis of the change in opening pressure. The high-tide convexity cell-C is very helpful. If we see no change, we think that we should change the pressure. If the cell-C are visible, maybe we have reached the right setting. And the collateral angle is also something useful in changing the pressure. The risk factors, of course, when the patient are under anticoagulant or antiplatelets, we think that the risk of subdural effusion is higher, so we decrease slower the opening pressure. And signs that might be related to intracranial hypertension, such as headaches, tinnitus, hearing loss, are the signs that prevent from decreasing the opening pressure. We balance all that and choose if we are going to change or not the treatment. This is an ongoing work, but in our data, about 40% of the patients keep the 2,000 millimeter of water opening pressure. 30% need one change to the next setting, and 20% needs 2 or more adjustment in the opening pressure. The second change is when we achieve 110 millimeter of water, and if the patient is not improved at that step, we discuss about shunt failure systematically. We have 4 steps to deal with shunt failure. We talked about that in the session just before. The first point is to suspect shunt failure, and in normal pressure hydrocephalus, it is mainly that you have not the improvement you were expected. So that is something very subjective and difficult to determine, or it could be a clinical worsening after an initial improvement. If we don't observe the improvement we are waiting for, we decrease the opening pressure of the valve, and if no improvement at 110, we test the valve. Well, we have 2 next steps: confirming the shunt failure and identifying the etiology of the failure, and 2 means to achieve those goals: imaging and hydrodynamics. Imaging is very important. The morphological imaging allows us to make the difference comparison between the pre-shunt and the suspected shunt imaging, and especially with the DASH criterion, looking for difference, are they existing or not. When we are trying to find the etiology, we use low-dose CT scan. It has shown to be better than plain radiography to identify precisely if a catheter is disconnected or not, or broken or not. And with low-dose CT scan, the radiation dose given to the patient is lower than with radiographic, so it's a straightforward procedure, more efficient than plain radiography. Hydrodynamics is very important because this is the way to ascertain that the valve is working or not. We systematically implant a pre-chamber to the shunt. It is an easy way to test the efficiency of the shunt. You just put a needle in it, record the pressure, and the pressure gives you a first information, but very often in normal pressure hydrocephalus, the pressure is normal, so it gives you no clue. If you do the infusion test, you can measure the R out and have another plateau. We use the ICM Plus software, where you have some kind of reference curves for each kind of shunt, And it really helps answering the question, is the shunt working and is it working properly as you are waiting for it? It is very important to identify where the problem is. If you have a pulsating curve, you know that the proximal part of the shunt is patent. And if the air route is very high, maybe the problem is downstream. So it helps you tailor the surgery if you go for a revision surgery. This is an example of, I will not go through the history of the patient, but mainly difficult clinic with a patient having headaches when the weather change. So you never know if the patient has really ICP problems or something else. And I had the opportunity of seeing this patient. He was treated in another center, but I could see at different times in history. And this first test shows you that the valve was over-draining with a very low opening pressure, a very low R out, and increasing the opening pressure of this patient alleviate the symptoms. A few years later, he had had several surgeries and come back without shunt, and the infusion test was suggestive of hydrodynamic problems. He was operated on, and again, with a shunt failure, it was easy to evidence that despite the numerous explorations he has had in other hospitals. Then you can tailor treatment and just do what is necessary according to the problem. Change the proximal catheter, the valve, or the distal catheter, or remove the whole valve. When nothing is observed, no failure, and you are sure that the valve is working, you can ask for your colleagues to look for other pathology that can be responsible for the symptoms and treat the symptoms with this knowledge that the valve is perfectly working and that you don't have to operate again on the patient. We systematically, when we do revision surgery, rule out infections by culturing the valve and the catheters. It is very often that you can identify germs such as Cutibacterium acnes that are very difficult to cultivate. You have to keep the catheter in culture for more than 1 week to have these germs, and they are very often responsible of late shunt dysfunctions. Let's go now through the series to have an idea and comparison with Guillaume's one. I just took the last surgeries from October 2011 until now. We've performed 506 shunt surgery. The vast majority of them was VA shunt, 82%. And 3/4 of them have been performed under local anesthesia with sedation. This is an idea of the age of the population. The main group is the INPH group with older patients. This is 383 patients. This group is a group of patients that had hydrocephalus in childhood and are transitioning in our center. And this is secondary INPH, like in every neurosurgical department. We have a slight male predominance because of INPH. This is the primary shunt insertion doing in Beaujon, so the first shunt in our department, about 400 shunts. 351 were for INPH, and only 2 had a VP shunt. All the other ones had VA shunt. The indication for VP shunt is mainly if there are too many people in the jugular veins, pacemakers, or implantable chambers for chemotherapy. All the other patients receive VA shunts. This is the revision surgery we've performed in the same time, 97 surgeries, with the majority of patients coming from childhood onset, only 1/3 from INPH. The pyramid of age is almost the same than Guillaume, with in INPH a median age around 76 from 59 to 91 years old. These are the complications in the INPH group, where there have been 32 revision surgery. The most important reason for revision in our group is infections. And then over drainage, we have no disconnections. This is the time lapse between revision surgery and first surgery, which can be quite a long time ago. This is time in months or more than 10 years, even for infections, that is the Cutibacterium infections. Why do we have very few misplacement? And I think that this might be due to the systematical use of neuronavigation, even if in the literature it is not that clear that helps. I think that there are two important things in neuronavigation: putting the catheter in the right place and putting it in only one attempt. These are the revision for the whole cohort, including the patient from transition. That means that in revision, most of the patients are coming from other centers than ours, so different surgical techniques. The main reason for revision is over drainage, then obstruction and infections. And there are some disconnection or fractures of the catheter. And if we focus on them, we've seen 3 distal disconnection. One is the one you can avoid if you use a pre-connected catheter. It was 11 years after implantation of a VP shunt. And 2 disconnection of additional connectors that have been adding during revision surgery. Why focusing on that? Because this is the very important message. Do not use that kind of device where there are no pre-connected catheter. This is an easy way of having more difficulties. You can put the valve in the wrong direction and you can have disconnection. If you use something that is pre-connected in industrial ways, it is always better than all the notes you can do. So this is a way of avoiding a large part of deconnection along the time. So the conclusion of the whole talk would be that it is very important, that is the same thing than the preceding session. We really have to be very efficient in our surgery. There are a lot of uncertainties in INPH, so we should not add technical pitfalls or things that we can avoid for our patients. State the obvious, use pre-connected devices. It is better to avoid disconnection or other problem. I strongly advocate the use of neuronavigation. It is an easy tool that we all have in our departments. You just have to press the button. And I think it's important to standardize the way we work from diagnosis to treatment. And I hope that you are now convinced that hydrodynamics helps understand case and even helps rule out revision cases and shunt failure. Thank you for your attention. We're now open for discussion, of course, and take